Okay. So welcome everyone on board. Actually, unfortunately, I couldn't take the session yesterday, and even today I was a little bit late, but I will just try to have some words. Um, this GIT, including all surgeries, clinical conditions, critical incidents related to, I have just tried to chalk out that what are the topics which you should be knowing about it. Okay. So a number of topic I have discussed before in various session. Um, and today I will just try to I will continue. We had one discussion before about intestinal obstruction. Okay. So, and first of all, just may I know, Dr. Faiza, are you exam candidate? Anyone who is appearing for the upcoming exam?
Yes, sir.
Okay. So, I would like you to have some, just try to answer or participate. Okay. Um, so we will just have a look on. Do you know what are anesthesia consideration in infantile hypertrophic pyloric stenosis? Yes, please.
Sir, its main concern is vomiting,
Very good.
dehydration,
Okay. What else?
and there is increased risk of aspiration also.
Okay.
Then these are usually neonates or infants.
Okay. What else?
Electro electrolyte imbalance, sir.
Okay. What sort of electrolyte imbalance we have here? What actually happens?
Bicarbonate and
Sorry?
sodium
Bicarbonate what?
hyponatremia.
Sorry?
Sir, hypokalemic, hyponatremic, hypochloremic, metabolic alkalosis
With, it's still missing one point.
with
Hyponatremic
aciduria.
paradoxical aciduria. What is this paradoxical aciduria?
Sir, no idea. I get confused
No
with
problem.
this term.
First of all, you said it is usually can a baby with infantile hypertrophic pyloric stenosis will survive without the surgery?
Yes, sir, he can survive because it's not an emergency. First, we have to
No, no,
correct his
uh,
electrolyte and
no, no,
dehydration.
no, no, no. Very good. You are right. You are absolutely right. It's a medical emergency, not surgical emergency. My question is that will the baby survive to become a pediatric patient, or usually it has to be done within few weeks? He will survive only up to few weeks. After that, the baby will not survive unless you intervene. Okay, because it's narrowing of the passage of from the stomach to intestines. Am I right? So baby will not be able to take proper feed. Okay, and as the requirement will increase, baby will not survive if you don't intervene. So usually the presentation is in usually around 3 to 4 weeks. Okay, so this is what we were talking about. Paradoxical aciduria means that if, for example, there is metabolic alkalosis, means there is high bicarb. Okay, so actually the body should kick out uh, bicarb and conserve hydrogen. Am I right? Am I right, Faiza?
Yes, sir.
But instead of taking care of hydrogen, it is kicking out hydrogen. It should conserve hydrogen. Am I right? There is already alkalosis. So instead of retaining the hydrogen, it is excreting hydrogen. Do you know why? Do you know what's the reason for it?
No, sir.
Okay, I will try to make you understand rather than cram. Just tell me one thing. Whenever there is hypovolemia, which hormone in our body react? Normal in on normal scenarios. Like what's the response to dehydration?
Sir, ADH hormone releases.
ADH, and there is another one. ADH is mainly with the water. Okay. What is the other hormone? Have you heard of this hormone?
Yes.
Okay. So it increase sodium and kick out potassium. Okay. So that's why if you now you can correlate that we have potassium sparing uh, diuretics. Okay. Which are aldosterone antagonist. Okay. Sorry. So actually aldosterone antagonist. So normal body response to hypovolemia and dehydration and electrolyte imbalance, hypovolemia is aldosterone. Okay. So here patient is losing hydrogen. Okay. One more thing, just to make you understand why there is hypokalemia and hypokalemia and hyponatremia, and why there is alkalosis. Can you tell me?
Because, sir, the patient is vomiting, so all the gastric fluid
Very good.
is
So sodium
is
is lost,
yes, it's
hydrogen
compound.
is lost,
Yes,
chloride
sodium.
is lost. Okay. So another, normally when we vomit, there is also intestinal secretions. So some bicarb is already lost. Okay. But here, because the door between the intestine and stomach is closed, so there is nothing coming from the intestine. However, when there is negative peristalsis as occur in intestinal obstruction, that vomiting also has bile. That vomiting also has bicarb. Okay. So here what will happen, that all bicarb will be absorbed. Okay. So we are losing hydrogen, we are losing chloride, we are losing sodium, we are losing potassium through the gastric fluid, and hydrogen is smiling and absorbed too much. So now the body response is aldosterone. So aldosterone is trying to conserve sodium and kick out potassium. Okay. But one stage comes that hypokalemia became so severe that it is not compatible with life. So at that time, instead of potassium, it kicks out hydrogen. Okay. So it conserves potassium and kicks out hydrogen. So this is the reason of paradoxical aciduria. Now you will, if you understand, you don't need to cram and you will never forget. Okay. So it's paradoxical means other than normal. Paradoxical. Okay. So paradoxical is the not the normal response, it's the opposite response. So this is what happens. Okay. So I hope you will not miss it. That's what they have written here. The same thing. Okay. That sodium, potassium, gastric acid is neutralized by pancreatic bicarb as it crosses the duodenum. In case of vomiting with an intact stomach and duodenum, both acid and hydrogen bicarb are lost. However, in cases of pyloric stenosis, only hydrogen is lost, resulting in a net increase in bicarb. Okay, that's what I was telling. Increased bicarb reaches the proximal convoluted tubule and overwhelms the reabsorption capacity, resulting in a loss of bicarb in urine as well. Like not only the bicarb is absorbing more, it is initially there is alkaline urine because bicarb will not be able to absorb. Then extracellular depletion occur, and it will causes the sodium by stimulating aldosterone secretion and causes kaliuresis, loss of potassium ions in the urine. Loss of potassium in urine and extracellular to intracellular shift of potassium due to plasma alkalosis causes significant hypokalemia. Hypokalemia forces sodium absorption in exchange for hydrogen. Okay. So they can ask you why this occurs. So be ready for, remember one thing, if you don't know the reason, you don't know the fact. Because facts are also known by the non-doctors. So the difference between an anesthetist and a paramedical staff will be the reasoning. They might know the facts, but they don't know the reason. So whenever you are studying anything, try to find out why, how, why, how. Don't cram the facts, because facts cramming will be lost. If you understand, if you understand this fact, you will never lose. Okay. So my next question is that we discussed in our last session as well. So how will you assess fluid loss? Like we have to label it as mild dehydration or moderate dehydration or more severe dehydration, less than 5%, 5 to 10%, and more than 10%. So this is the calculation of. So what thing you will be looking at, Faiza, or anyone else want to tell?
Sir, we will look at the urine output of the patient's skin turgor, mucous membrane, conscious level, activity level of the patient, sunken eyes or not.
Okay, so actually divide it in a way that it looks good. Okay, so you have told everything, but a little haphazard. So you can see urine output is one of them. Sign of circulation is another thing. Okay, and the conscious level is another thing. So for signs of circulation, you will see in the skin or mucous membranes. Okay, and in babies, there is like fontanelle, so sunken fontanelle. Okay, conscious level you cannot assess in babies in a well way. Only if the conscious level will become obtunded or baby may be crying. Okay. In adults, when you are evaluating, so anxiety will be here. Another thing is that usually in adults there is hypotension and tachycardia. Okay. However, this will not be very prominent in this age group. Do you know the reason why? Yes, Faiza, if someone asks you why it's so, what's the reason of not having adequate response like this?
Sir, I think because sympathetic or parasympathetic, I'm not confirmed, the system is not fully developed.
What do you mean by not again? Don't tell like this in the exam, okay? Because how can it be parasympathetic? Parasympathetic system in this is a stressful time. So which system do you think will be stimulated? Parasympathetic or sympathetic?
Sympathetic.
Sympathetic.
Sympathetic. So rather, why the babies are tending have more tendency of, because there is predominantly more vagal, there is more strong vagal supply and less developed sympathetic system, and the reflexes which occur normally if we are sitting and suddenly stand up, there is pooling of blood, there is sympathetic stimulation, tachycardia, vasoconstriction, and the blood pressure is maintained. Okay, in the babies this response is not very well placed, and that's the reason these sign symptoms are not very prominent in this age group. Okay, so you will be looking at the skin turgor, capillary refill. Okay, capillary refill, mucous membranes, and then you, as you tell, urine output. So urine output, the like, because it will be bare this baby, sorry, in babies it's very difficult. Usually adequate urine output is at least 0.5 to 1 ml per kg per hour. Okay, so here you will be looking at the pamper, that how much bed wetting, this how many pampers are wet. So this is how you will be. So this is what I was telling you. Okay, so this is how you assess normally. This pulse rate response is not as developed in pediatric age group as in adults. Similarly, the vital signs, you should be looking at the vital signs. So vital signs should be the main priority. This should be in your tips, because this will be not only here, it will be in any other condition in which there is this this one uh, dehydration. Okay. So next step, which fluid should be given? Anyone else want to participate? Iqra, you want to answer, or anyone, because I don't know who is iPhone. Any other exam candidate want to speak out? Which fluid you should give?
Sir, we can give 0.9% normal saline at the rate of 20 ml per kg.
Okay. Why it only 20 ml per kg?
Sir, if the patient is dehydrated, severely dehydrated, so
Hmm.
that will be initial bolus.
So if I'm not wrong, it's per percent at, 10 per percent dehydration. 10%, 10 into, yes, it's like that. Weight into percentage into 10. Like for example, if you have a 10, now I'm telling you for example that if you have a 10 kg baby and the dehydration is 10%, so you will be giving around 1 liter, because 10 into 10 into 10. Okay. So of course this baby will not be 10 kg, baby may be around 3 kg or 4 kg or 5 kg, like that. So accordingly, if you multiply by 5, so it will be 500 ml. Okay. And as you mentioned, 0.9% saline. Uh, so we discussed a number of time before that it's not normal. I label it as abnormal. Why? If someone asks you why 0.9% saline is not normal, it's abnormal. What's abnormal about this solution? Can anyone tell? Yes, Hasham.
Sir,
It
it's
has
the
one,
pH.
not pH. It's 154 of sodium and 154 of chloride. It's crazy. So sodium is around 130 to 140 and chloride is around 100, 105. So it's too much. So it is causing hyperchloremic acidosis, because chloride will combine with hydrogen, it will cause acidosis. So it's not a good solution. But in this scenario, when there is hypochloremia and there is hyponatremia, it's a better choice. Then when would you like to add uh, potassium? Would you like to add potassium when there is urine output? Okay. After you get some urine output, you will, and then when will you say that dehydration has been, like, when will you say that the patient is ready for the surgery? There will be urinary chloride. Okay. The dehydration will be settled down. There will be adequate amount of urine output. Then sodium, potassium, uh, like all electrolytes will be in this condition, and then you will do 4 quadrant suctioning. Okay. And then the
इसमें
patient,
सर जान भाई
yes.
मैं इसमें ऐड करते जाऊँ अब पाइलोरिक सिनोसिस आप लोग
Try
डिस्कस
to
कर रहे
speak
हैं
in
तो
English. Awais, try to speak in English,
okay
because
okay sure so our targets are pH should be around 7.5 chloride should be more than 90 right in this patient and bicarb should be less than 30 so these are the targets we aim for and of
okay,
course there should be urine output and patient should be adequately resuscitated before
very good.
taking for surgery.
Okay, so that's what is written here as well. So metabolic targets for resuscitation include, you will find it in all the articles and everything. And I think this was a number which someone was telling, 20 ml per kg. So actually you can say in a different manners, you can say, like you can give a goal directed fluid. You are targeting the goal, and then you are giving some fluid, look for the signs of overload, and then you are and also you are replacing the ng, because you will pass the NG. So any losses in NG you will also replace. You will check the electrolytes. So this is how you will proceed. Okay. So this 4-quadrant suctioning, and you will be expecting this baby will be at risk of aspiration as well. And once you like all the physiological, pharmacological, and anatomical consideration in any neonate or any pediatric patient will be there. So with reference to IV cannulas, with reference to development of hypothermia, with reference to not fully developed kidneys or liver, high blood volume, okay, high volume of distribution. Initial high doses will be required and less maintenance doses will be required. You need to dilute in standard concentrations so that there is no chances of errors. So these are the general consideration which you will be doing. The patient, if not corrected properly and try to be anesthetized, the patient will have central apnea because of electrolyte imbalance and will be difficult to be weaned off. Even then, because if the baby is premature, for example, or still there are some residual electrolyte imbalance or things like that. So the baby might have some post-operative respiratory problem. So it's better to monitor the patient in HDU or ICU post-operatively. So this is how you would be uh, this one managing this case. The temperature monitoring just came. So what do you think? What would be a more reliable site of temperature measurement? Can anyone tell? Wes, are you in habit of using rectal temperature?
No, we're just using lower esophageal temperature monitoring. So we keep the temperature probe through the mouth. We
Yes,
don't use the
actually,
nose because risk of bleeding is there.
risk of bleeding is there, and another thing is that it's not reliable, because there will be a conduction current through the dry gases which we are giving. So the nasopharyngeal will not be a very good. The advantage of rectal will be that it will be more accurate. It will be a little higher, okay, but it is more reliable. Yes, if you are able to place it in mid esophagus, that will also be more accurate. By the way, what is the most reliable indicator of core temperature? Like from where you will get the most accurate one? Anyone, please?
PA, pulmonary artery.
Pulmonary artery catheter. But this is more of theoretical stuff. Nobody use it. There is another this tympanic membrane. I think it's also telling the core temperature, if I'm not wrong. I have not used it. Of course, this is just matter of just your knowledge. Skin is unreliable, because if you place the temperature probe, skin temperature, and the same place your this bear hugger is working, so it will not be a reliable. I don't think so. Skin temperature will be a very reliable one in these cases. We have bear hugger. Not if someone has not seen bear hugger, it's like a air mattress, air you can say a device through which
Circulator.
warm. I'm sorry.
It is like an
Sir,
air mattress. You're right. It is an air mattress.
It's
You
like
can
an
keep
air
it
sir,
mattress,
how do
because
you
above
have
the
to
patient.
notice? No, no.
actually there is a warming mattress which is separate, in which the bed is warm. Okay, like
Fluid.
the
Yeah.
yes. So this is one of them. So like bear hugger is another one. You can Google. You can do
Okay,
Google the
go
picture.
ahead.
So warming mattress, ambient temperature should be around 25 to 26 degrees centigrade. Though practically the surgeons never allow this, and this is always a fight which goes on between the surgeons and anesthetists regarding the pediatric population. They are not happy because they start sweating and they say, if we will sweat, we will the sweat will go to the surgical site and it will cause infection, and then we will report that anesthetist is the culprit who make us sweat. Okay, so this is practically nobody. This I doubt this temperature 20 to 22. The ideal body, the ideal and temperature in the OR should be around 25, if I'm not wrong. Just correct me if I'm wrong. Okay. And then all
You
the
are
concern.
correct. It should be. 25.
Yes. So
25 to
remember,
27.
yes, remember one thing, never ever follow a single. This is an excellent book. I used to say that it is just like in Punjabi. It's so simple book that it's like a slang language book, this book. But you see, so many mistakes or so many questionable things you are finding. So this is one of them. It's not 20 to 22 degrees centigrade. Remember, this is wrong. Okay. Similarly, the all other concerns, you are using some anti-salagogue. Um, and people are giving atropine a profile. I don't think so. It should be a practice. Older anesthetists, they used to give atropine as preemptive. This is structured oral examination book. Okay. So for dehydration, you will be giving isotonic fluids, and for correction of like if you are expecting hypoglycemia, so you will be checking the blood sugar, and for maintenance, you can give this 0.45% saline with dextrose. Okay, and the rest of the things will be like local infiltration and multimodal analgesia, paracetamol, suppositories, or diclofenac. People are giving some people. There will be a question mark in using NSAIDs in younger age group. There is a debate. I'm not sure what does the data suggest. Wes, were you using NSAIDs in younger age group?
Less than 3-year-old, we are not using. Less than 3-year-old, it's not recommended. So less than 3-year-old, we don't use diclofenac. If patient has any renal impairment or evidence of any renal issues, then we don't use at all.
Okay, okay,
NSAIDs completely don't use it. But you can only use suppositories. Ibuprofen suppositories are available
Mhm.
for smaller children. But diclofenac, avoid it above 3.
Okay.
Below
So,
3, sorry.
doctors,
Avoid it below
yes.
3.
So, Dr. Sumera, your question, that the PDF link is waiting for you to have a look. It's just crying. Nobody looks at the link. Nobody looks at the link. If you open the link, you will find books arranged in folders. So it's a review book. So you will find it in clinical review books. Okay. Anyway, so some quick review about the anatomical and physiological changes in pediatrics. So you see large head, short neck, large tongue, small mouth, okay, narrow obligate mouth breathers, easily blocked nasal passages, okay, sorry, obligate nose breather, because tongue is falling and blocking it. So that maintaining patency of nasal air passage is very important. Epiglottis floppy and U-shaped. Larynx is positions higher. The shortest, the sorry, narrowest point of airway is cricoid cartilage, rather than vocal cords. Okay, and
This
so
is
the
false, actually. This is now changed. Recent guidelines, there is a narrow portion for adult and pediatric is the cricoid.
okay, okay. So anyways, any trauma can easily result in edema. The trachea is short and this predisposed to endobronchial. So it's very important to fix the tube with very good, and of course, the role of ultrasound, if possible, will be there to confirm the site of the tube. Okay, and easy desaturation, low FRC, and then oxygen consumption is more. So not only the consumption is more, because of FRC and less developed ventilatory responses, all these problems will lead to the hypoxia or bradycardia during airway manipulation. Okay, so fixed cardiac output, as I've already discussed, that response to cardiovascular response to sympathetic stimuli in the normal way will not be there. Okay, so so cardiovascular response to hypoxia and neonates is bradycardia with pulmonary and systemic vasoconstriction. So heart rate dependent cardiac output, fixed cardiac output, renal blood flow and GFR is low, and they are sodium losers. Okay, that's why we should not give hyponatremic solutions. So temperature control is also very important because of high body surface area and shivering mechanism. So there is non-shivering thermogenesis. So you should be knowing where is the location of brown fat. Ikra, can you tell where are brown fat?
Sir, it is between the scapula on the back.
Okay. Anywhere else?
Sir, one more side. I can't remember. It's
Okay.
on the dorsal surface is mostly, sir.
I don't remember
So
either.
mediastinum.
Mediastinum. Okay.
Mediastinum.
Yes. So brown fat,
And I
non-shivering.
think it's somewhere about
Adrenal.
adrenals, yeah.
Adrenals.
Okay. So they are just telling some more thing, 4-to-1 formula. And third, just one more thing I want to just highlight a little bit. It's not 100% relevant, but because we are, whenever we are, one is deficit, okay? One is maintenance. One is third spacing. And then insensible loss, like with respiration and everything, okay? And then the drains, okay? And you will calculate allowable blood loss. So above allowable blood loss, you need to replace with blood. And below allowable blood loss, you will replace blood in 1:1 with the colloid and 1:3 or 4 with ristolite. Okay. So deficit is our NPO or in this case, any pathology. So the deficit is according to the clinical judgment. Otherwise, if deficit is with the NPO, usually if you are not replacing fluids, so deficit will be the one which is since NPO. If you are properly replacing the deficit, then you don't need this. Deficit is relative. Okay. Then maintenance is with 4-to-1 formula. Third spacing according to, like, for example, if there is intra-abdominal or intrathoracic, so it will have around 5 to 8 ml per kg. Okay. And then insensible loss is around 1 to 2 ml, if I'm not wrong.
Per
So it's
hour.
1 to 2 ml per
Per
kg per
hour.
hour. Okay. And drains
Up-
according
Yeah,
according
up
to
to
the
10
situation.
ml per kilogram per hour.
Yes. And one more thing is that actually consider urine output as also a drain. Okay. So make sure that you are not giving the lesser amount than urine output. If the urine output, because in some condition, any condition, there will be high urine output as occur in traumatic brain injury, or so you have to replace the urine output as well as a drain. Okay. I know this is a crazy concept, but it's like that. And then rest of the things. So this is very important to have. Okay, no problem. I think you can ask your wife to just press your throat so that okay, Asham. Okay.
Sir,
Yes. Okay. So
completely unable to speak at the
no
moment.
problem. You can ask
Severe
your
throat.
wife to press your throat so that your problem will be solved. Okay, so actually, because I tried to start the session a little early, I will just give you an idea about what we need to know from this stomach, esophagus, and this. I have just maybe some of the points I still need to do, but I will try to cover in coming days. So actually, peptic ulcers, the treatment of peptic ulcer, and I'm sorry. Okay. So, you should be knowing the mechanism of action of PPIs, H2 receptor antagonist, and their anesthesia relevance. We discussed in our last session about PPIs are enzyme inhibitors. Cimetidine is enzyme inducer. Okay, so you should be knowing a little bit of correlation, and then this one. How is their use, okay? And then the concept about aspiration pneumonia, how to calculate the residual volume through ultrasound, through POCUS you can do it. And then what is the treatment of aspiration? So we will just try to cover these things. Concerns with reference to orogastric and nasogastric tube concerns, like it's like a foreign body. It's irritant. It open up the lower esophageal sphincter itself. It predispose to the uh, aspiration. Okay. So, and also you need to know how to calculate the distance from the nasal to the stomach. Okay. Then concerns in a carcinoma patient, like there may be local access to a vascular structure. Okay. There may be metastasis to lymph nodes, and then metastasis to vital organs like liver, lungs, brain. Okay. Bone. So all this will be concerned. Then patient will have pain. Patient will be, maybe if there is pain, maybe patient is on opioids. So opioid dependence concerns will be there. Okay. Then the patient is maybe taking chemotherapy or radiotherapy, or there is some like stoma creation, especially in cases of abdominal carcinomas. Maybe the patient already have just palliative surgery. They are just relieving the obstruction just to have a easy death. Okay. So like there is also question which was asked once on palliative care. What is the role of anesthetist in palliative care? And then there are some pain relief procedures, especially with reference to abdominal surgery, like celiac plexus block. Okay. It also is used in intractable pancreatitis pain, or so these are the things which you should be knowing. The problems with associated with the chemotherapy, because chemotherapeutic agents all block the normal. They are and they are not only destroying the cancer cell, they are destroying the normal tissue body cells as well. So they are associated with bone marrow suppression, they are associated with myocarditis, they are associated with liver dysfunction, renal dysfunction. So there are so many things which are disturbed when the patient is taking chemotherapy. That's why whenever they start chemotherapy, they do a baseline echo, and then they follow not only clinically but also they repeat the echo after the cycles of chemotherapy are finished. So these are some important points about any carcinoma. Yes, if the site is involving any area related to airway. So airway like CA tongue or oral tumors or any tumor in the neck, like in thyroid tumors, they are compressing the airway. Even parotid tumors, they are creating problems. Salivary gland tumors, they are also creating anything related to airway. This is an additional problem. Otherwise, any other place, these will be the common concern which I have told. Okay, pain, spread, chemotherapy, radiotherapy, any palliative surgery, this opioid dependence, these are the common concern. And then there is anemia. Okay. Not only because of any loss, especially again, abdominal tumors, intestinal, anything, there may be upper GI bleed, there may be lower GI bleed. There is anemia of chronic disease. Okay. Also, these chemotherapeutic agents can cause anemia. So concerns related to anemia will also be there. So upper GI bleed management, actually, there is a long. Can someone just tell what will be the differential diagnosis of upper GI bleed? Faiza, Iqra, or any exam candidate, or Ibrahim? I don't know who wants to speak out. Differential diagnosis of upper GI bleed.
Esophageal varices,
और हाई हो सकता है सर
I'm sorry.
peptic
Varices,
ulcer disease.
varices,
Revis,
ulcer.
Revis and more high.
I'm sorry, I cannot re-hear you. Again, please. Varices, ulcer. What else? Carcinoma. Don't forget bleeding disorders, because you will tell varices and ulcer, and but you might forget bleeding disorders. So bleeding disorder, never forget. Okay. This is in differential diagnosis of any trauma. Okay. Okay. So how to manage? Again, the common thing will be the same. Airway, breathing, circulation. Here, aspiration risk will also be there. And because upper GI bleed, if it is not coming out, maybe you are not able to identify how much blood loss. Okay. So you might need to pass the NG tube. So again, the concerns related to NG or orogastric tube will be there. Okay. And then you will assess the level of hypovolemia or level of anemia, and then you will correct accordingly. So this will be one thing will be resuscitative, and the other thing will be that either there is sclerotherapy, either there is bending, or there is some pharmacological therapy with terlipressin or things like that. Okay, so we can have
Octreotide.
octreotide. So like these are the things which you should be knowing. And then there is another Sangsticken blackboard tube, if I'm not pronunciating in a wrong way. Uh, I have never seen or never used it, but you should be knowing this name also. In addition to the balloon tamponade, sclerotherapy, medical management, or if it is like you are giving the ulcer treatment. So these are the things which will be common in management of upper GI bleed. Okay. Uh, okay. You should be knowing how GI secretions are being controlled. Some of the, I don't remember, recall the physiology, but they can ask you in long case how GI secretions are controlled, how much secretions, how much is saliva, how much is gastric fluid. So you should be knowing about it. Then ulcer treatment pharmacology, I've told you. Gastroenteritis will result in dehydration. So actually, there are so many things which are related to, and gastroenteritis patient can go into sepsis. So whenever things like that come, you should be knowing about it. Dysphagia, differential diagnosis of dysphagia. We will just try to cover some of the topics in our coming sessions. Okay. So actually, I will stop here because it's quite late. So we will continue our discussion on this. Uh, uh, we in a previous session we discussed about intestinal obstruction. Okay, so tomorrow maybe I will just try to have some words about abdominal compartment syndrome and maybe pancreatitis. Let's see how it goes. Okay, so thank you very much. Any question? I'm just trying to make a list of the surgeries so that we will also discuss about the some of the surgeries. Okay. So my suggestion to you, study like this: physiology, pharmacology, anatomy, pathophysiology, medicine, and surgical concerns. And you correlate them with all the steps of anesthesia, like pre-medication, anxiolysis, airway management, monitoring, induction agent, muscle relaxant, analgesia, fluid, OUNV prophylaxis, aspiration prophylaxis, like as an anti-inflammatory medications. Then where to send the patient after the surgery, sending back to home as day surgery, sending the patient to ward, sending the patient to HDU, sending the patient to ICU, intubated or only for monitoring. Anything, fit all the surgeries, dissect all the surgeries in this way. Okay, all the diseases in this way. Yes, one thing I missed is specific surgical and a specific positioning required. So all the surgeries, if you dissect like that, things will become very easy. And any critical step like trocar insertion, insufflation, absorption, and tourniquet placement, tourniquet release, converting the patient in prone position, converting the patient in head down position. So these are all concerns. These are all practical concerns which you can face. So instead of, because you will not find these facts in the books, remember. Okay. Yes, abdominal compartment syndrome will affect. Unfortunately, no wives. So I pray for you, Hasham. Uh, Okay, so thank you very much, all of you, my dear friends. Inshallah, we will just continue our discussion. Okay, so feel free to drop a message to ask anything anytime. Bye bye.